what did you think about it? What diagnosis did you make, and what did you do to set it right? And how can you really get that to become all right?
Since it's a elderly patient, we thought it would be postgraduate
So obstructive uropathy. You thought of obstructive uropathy, and that is causing reduced urine, maybe retention of urine. So how do you do your retention of urine? Yeah, you catheterizing and you found that there was a retention?
Yes.
How would you know retention? Basically the patient is unable to void, and then when you put it, a lot of urine comes out, bladder becomes smaller. So you thought that it was basically retention failure, not actually a renal failure. It was basically just a urinary outflow. So then what did you do?
We sent for ultrasound.
Yeah, ultrasound will not tell you anything about obstruction unless you are thinking of a hydronephrosis. So to address that you did that, but will the ultrasound help you in an obstructive uropathy and what way? That is very difficult to really know in ultrasound, but what you could know is obstructive uropathy features. So what are the obstructive uropathy features in ultrasound? Yeah, those are all vague things. I mean, somebody can just interpret it that way, but most importantly, what you can grossly know is the obstructive uropathy features. What are they? If you really had one. So that would be ureteric dilatation, pelvic LECL dilatation. Because of the obstruction there, so bilateral it will be dilated. So was it there? It wasn't there. So the BPH is like you see some volume of the prostate and see that. It's really difficult to say. And at this age it's more of a clinical diagnosis. More like saying COVID pneumonia is having HRCT findings of ground glass opacities, GGOs, and COVID pneumonia can be diagnosed by HRCT. Something like that. But actually that's not true. I mean, it's only because we know that this patient is having COVID and he is having these HRCT findings, we are correlating with it. And similarly here, we know that this is an elderly patient likely to have BPH, having kind of obstructive features. So we are looking at it and we are giving a biased viewpoint of this is. So he came and obstructive BPH of the prostate. But anything else? We had developed a urinary infection on top of that. Explain his fever. He didn't have any features of it that much. Good, I think there was a very short period waiting for your so immediately we start with the person.
Leading to disturbance in daily routine activities. And it is mainly associated with pain, cognitive disturbances, and the criteria for the diagnosis, it is new onset, it should last for more than 6 months, and it should not have any organic causes, and it should have falling features like more than or equal to 6 falling, more than equal to 4 falling features like sore throat, cervical and tender cervical and axial lymph nodes, and myalgias, joint pains, new onset headache, sleep disturbance, amputations, predisposing factors like premorbid psychiatric illness and pathophysiology. Actually, there is no proved etiology for that. They found that on neuroimaging, they found that there is a loss of volume, cortical volume, and raise in interleukin 1, which explains the symptoms like asthenia. MRI and CT will also be normal. Treatment is cognitive behavior therapy and graded exercise therapy. Cognitive behavior therapy of 14 sessions lasting for 3 to 6 months, and graded exercise therapy for 6 months.
Ready.
I would like to discuss about tumor lysis syndrome.
Yeah, are you using this?
Working.
You can throw your voice. Good. You can hear me. What is
Tumor lysis syndrome is a very common oncological emergency seen after initiation of chemotherapy in malignancies like lymphoproliferative malignancies, lymphomas, and small cell lung cancer. Malignancies which have a high proliferative rate and rapid tumor burden and high chemosensitivity are more prone to tumor lysis syndrome. This usually occurs after the initiation of chemotherapy, and some tumors like Burkitt's lymphoma, in these malignancies, spontaneous tumor lysis syndrome occurs. Actually, after the initiation of chemotherapy, rapid tumor cell burden will lead to the large amount of cells will be ruptured, and intracellular potassium is released, and the phosphates and the nucleic acids, which lead to the high levels of uric acid, and phosphate levels will lead to the reduced calcium levels. So this is the main pathophysiology. And the high uric acid levels will lead to renal failure, causing acute kidney injury. In diagnosis, there will be high levels of high uric acid levels, high phosphate levels, and high hyperkalemia. And hyperkalemia changes will be seen on ECG like tau T waves and loss of T wave and arrhythmias and sine wave patterns. In the patient will be presented with renal stones due to high uric acid levels. There will be high calcium phosphate crystals, which lead to renal calculi. And so mainly patients should be provided with high hydration. Adequate hydration should be provided before the chemotherapy, like 3 to 4 liters per day. And during the sessions, patients are provided, in case of mild to moderate cases, patients should be administered allopurinol. And in case of heavy tumor burden, rasburicase is used.
Alright, so coming to critical appraisal of this presentation, what are the points which would increase his score, or what are the points which are hampering his score from going above 50 or 60? So he has mentioned the definition well, he has mentioned the way it plays out well, like how it evolves into this. And then he has mentioned some interesting things like, these patients may develop renal calculi, these patients can develop urate nephropathy and renal failure because of urate nephropathy, maybe acute urate nephropathy. But acute urate nephropathy is still understandable. I am not sure this takes us into another topic of acute urate nephropathy and acute renal failure. So how do you explain it? I mean, how would the sudden rise of uric acid give rise to acute renal failure? This is something which we would like to learn more about if either today or tomorrow somebody can tell us about it. And other than this, what more do we need to do? Okay, then you went into, like you diagnosed it on the basis of these parameters. The setting is a malignancy, and ideally most commonly a lymphoproliferative malignancy. Sometimes in Burkitt's lymphoma it can happen spontaneously even without therapeutic challenge. Now when there is a therapeutic challenge, chemotherapeutic, the cells die and the cells release the products inside like potassium, calcium. Now we do not talk about calcium. That's the catch. That's the MCQ actually in the knee. So if this happens, increase potassium, increase uric acid, increase calcium, reduce calcium. So the calcium is reduced. So why?
Due to increased phosphate levels.
Phosphate binding. So whenever the phosphate increases, the calcium binds. So calcium phosphate byproduct creates hypocalcemia. So So that's another very important. So here, Dr. Vinod has to tell us about each and every problem and how each and every problem is tackled by a therapeutic modality. So here the diagnostic criteria, again, there's no instrument for it. It's just that the presence of these certain factors, one is the background, the obligatory criteria, that is the malignancy, and then therapeutic challenge with chemotherapy, and then the major whatever criteria where you have hyperkalemia, hyperuricemia, hypocalcemia, hyperphosphatemia. So that's it, simple. So diagnostic, I think you don't need to go into such specificity here because I'm not sure whether there are any papers on this as to how how meticulous you have to be in actually diagnosing this. And as you said, some of the aspects are even preventive. Like you are anticipating tumor lysis syndrome in a lymphophotoproliferative disease even before you start chemotherapy. So you start with prevention. Now you come to the efficacy of these interventions, either preventive or therapeutic. So if you are giving hydration, does it help outweigh other than logic? Yes, I think most of the time in medicine we use logic, driving our decision making. But sometimes things which are logical may not really turn out to be effective. So is really hydration effective? I think nobody has really studied this probably. Everybody would just say okay, hydrate because the kidneys are failing. So we have always got this in the back of our mind that if the kidneys are failing, the kidneys are not getting enough water. So hydrate. And I don't see but when the logic, why should these patients become dehydrated with chemotherapy and with the cells getting killed? So it may be worthwhile to look at this direction, but then again we have to review the literature. So if you review the literature, you see what is the efficacy of hydration. You try to find out what is the efficacy of, let us say, what do you give for hyperkalemia for these patients. So it's a different topic altogether. It's a very short note, both in the MBBS level and the MD level, hyperkalemia, interventions. So can you tell us about the hyperkalemia interventions that can be done here?
Insulin.
Okay, so very often we use dextrose-insulin in that logic that insulin will drive, dextrose will drive the potassium into the cell. So that comes from animal models logically showing us that it may happen in certain animals and certain cells, in vitro, in vivo. But when we talk about evidence-based medicine, we talk about what is happening in terms of human intervention efficacy. So when you give it to 100 humans, dextrose-insulin versus placebo, if that has been tried, what is the outcome of the dextrose-insulin group versus the placebo? If that has been done. So you have to search for that. You see, going into evidence-based medicine is easy because the formula is very similar, very simple. RCT and this comparator and outcomes. But then you don't, unless you search those studies, you cannot share them. So that is about the hyperkalemia and dextrose-insulin. But what about other things like ion exchange resins? Yes, and what else? Maybe calcium, yes, calcium gluconate. What do you know about calcium gluconate in tablets?
Stabilizes the
Yes, it's a membrane stabilizer. And how did we reach this conclusion that calcium gluconate is important? Like, as children we were taught that as soon as there is hyperkalemia, you just take 10 ml of 10% calcium gluconate and inject it into the patient. That's the first thing you do. So why? As you said, it's a membrane stabilizing agent. From animal model studies we have learned that. And I don't know your generation whether they did those experiments or not. We did those on rabbits or even frogs. We gave them potassium and killed them. So we came to realize when does the heart stop with hyperkalemia, when does the heart stop with hypercalcemia. In hypercalcemia, the heart stops in systole, and in hyperkalemia, stops in diastole. So to just keep that in our mind, we killed so many innocent minds. And of course, by your time, I think all these animal studies have been discontinued. So from animal models, we know that. It's surprising that nobody has actually done a placebo-controlled trial of calcium versus placebo to see whether this really has any role. It's probably just based on that animal model which was showing us that because it stops in diastole and that stops in systole, why not give that thing which stops in systole for something which stops in diastole? That's it. That's the simplistic logic, probably. But yeah, if you can find some literature and add to this, it will be very interesting. So I am hoping to learn from you today if you can review the literature around this topic of one intervention for hyperkalemia, that is calcium deficit. Now the second was insulin excuse. Third is iron exchange basis. Fourth is what are the other pharmacological interventions for hyperkalemia? Calcium carbonate, glucosamine, beta 2 agonist. Yes, salbutamol and all those beta 2 agonists. So there's one question here: how much of beta 2 agonist can reduce your potassium level by how much? If you give so much milligrams of salbutamol, how much MEQ will the potassium level come up? Because if you're giving it in the ICU, you will have to know this potassium level is 7, 8, how much will I give? So when it comes down to 4, yes, Praneet, how much will you give potassium? What is this computer? So, how much potassium, how much salbutamol will you give to treat a hyperkalemia setting and for how long? So this can be one question. And of course, I am actually going to review the literature and get back on it. Now, what are the pharmacological interventions? Now, what is the efficacy of all this? What are the trials available? So we did a review of literature around all this, and I was surprised to find that most of them are of no use. No. So what is the most efficacious intervention for hyperkalemia? Hemodialysis. Yes. That's the only thing which is proven that it is effective. All of them, the others are just, I don't know, help the pharma companies. But again, it's just a statement. And it's all being got on video and it will be all circulating. So, I don't know. So, alright. Good. So, diagnostic and efficacy of the therapeutic interventions. We come back to tumor lysis. So, hydration, allopurinol. Now, this can be studied. What is the role of prophylactic allopurinol in preventing tumor lysis? I'm sure some PG would have done this. But again, logically, can you withhold allopurinol when you think that somebody's uric acid is going to go up? And what is the role of uric acid in uric nephropathy again? How quickly does uric nephropathy happen if the uric acid just jumps up? And we know people have 7 and then they become 10 or 11, but that happens in gout also, but they don't have renal failure unless they have chronic nephrocalcinosis due to hyperuricemia somehow. Again, those correlations are not very well defined. So I think we need to look at that as well. So I guess even if you write these queries which need your evidence, that will also carry marks. So sometimes you may not be able to find the evidence. Obviously, you cannot find evidence for everything. But you can put your queries there and say that this could be a good project. That should also carry some marks. It is relevant, very relevant. It's not like writing somebody's wedding notes in the paper and coming back, thinking that because I've written a lot of volume, I'll get some. No, it has to be relevant to this extent at least. So, yeah, so I think it was a good presentation, Dr. Vinod. And so we move on to Dr. Sandeep. Yes.
So let's talk about Parkinsonism.
So that's a very broad topic, Parkinsonism. Yes.
This is a neurodegenerative disorder, and it is diagnosed by clinical diagnosis, and it comes.
Okay, so definition, then diagnosis, good. And it's a clinical diagnosis only. That's a very, very fascinating thing. Only disease to be diagnosed clinically even now. No diagnostic tool for it other than clinical findings. Fantastic, fascinating.
And features are rigidity, bradykinesia, and tremors. And these tremors are resting tremors and pillory tremors. And rigidity is like organ rigidity. And disease due to the pathophysiology is due to the degeneration of dopaminergic neurons. And also some studies showing that it is also due to the cholinergic neurons affected also.
So how does science prove that this is because of dopaminergic depletion? I mean, because when we were children, we just kept on reading, okay, dopamine is not there and Parkinson is happening. But how did scientists really reach this conclusion? Can you throw some more light on that as a PG? As a PG, most of them, whatever we read in textbook is accepted. But as a PG, we have to challenge those things. That's why you do research, you do some your thesis, because you have the ability to challenge. Of course, the UGs also have it, only they are not engaged to do it.
Actually, for motor coordination movement, these basal ganglia are very useful. So,
yeah, so you see, basal ganglia has some role in our motor movement. Yeah,
coordination of
broad,
movement.
yeah, coordination of movement. Okay. So coordination of movement means I am just moving now, and what will happen if my basal ganglia is not working? What is it coordinating right now?
So with
It is
cerebral
coordinating my initiation of movement. It is coordinating my speed of movement. Not balance, only speed and initiation. And that way this back calculating because we know what are the features of Parkinson. So we are just saying now. Speed, initiation and what else. So that is the attribute to basal ganglia why. Who found out or discovered that this basal ganglia is actually making us move properly. And how did they find it? So a little bit of history there, if you can. Now I'm just raising this because after this session you will go and find it. All of us will, and all of us will share and you will know. Because it's important to not let them die unsung. Somebody has really put in a lot of hard work for you to say that basal ganglia is weak. How did they do it? So again, there's a formula here. Each and everything that we are learning and know today has been found out by PGs of the past. What did they do? What were the PGs or UGs doing in the past, let's say 300 years back? People like Parkinson's. They were waiting for the people to die, the patients to die, so that as soon as they die, they would push them into the mortuary and cut them open to find out what really killed the patient and what really the patient had. Why was he not moving properly? So that is what they were doing. Once they found out the brain section, they found that this is different from the normal brain, and we expect to have some black substantia, nigrous area there in that part, which is not there. So maybe this is the chemical which is causing that movement or causing inhibition of that movement. Otherwise, that's the problem. So this is the formula. But yeah, what exactly they did, that you will have to do. But sometimes when you just put the formula in a skeleton, it will be relevant. It will not be irrelevant. So, okay, so this is the history part, the pathology part, whatever you could tell us. Pathophysiology, yes. And then?
Clinical features includes apart from bradykinesia, rigidity and motion stability, tremors, and these Parkinsonism also have some motor and some non-motor features. And motor features includes micrographia and mask-like faces and dysphasia. Non-motor features includes sensory disturbances.
So what is micrographia and what is dysphasia? Start writing normally and then your font size reduces and it becomes smaller. So why would that happen in Parkinson? What would be the mechanism? Why do you start normally and then start becoming smaller? So you see, one thing is to just keep questioning. Whatever phenomena is happening, you keep questioning. That's basically what science does. Science is skepticism. It doesn't believe in anything. It keeps questioning everything. And then it tries to correlate by finding newer things. So, okay, one is that, and what is dysphasia? Dysphonia, which these patients may have, why do they have it? So, this is because of affection of the vocal cord. So, it is not moving properly. Sound production will be not proper. And patients can even go to aphonia. So, what would be that? Some kind of a rigidity of the vocal cord? Just like you have bradykinesia, rigidity, the striated muscles outside. The vocal cord also you can have that. So is that true? So if people with aphonia, dysphonia were being examined by the ENT and was a vocal cord movement analysis done, I'm sure it was done, and was a biopsy taken from there to see what is happening there. Of course the muscle may be all normal. It is basically the current which is causing all this problem. Locally the muscles are not. It's just the signals from the brain which are problematic. So you have to expand on these things. That's the way to get more marks. That's what I'm suggesting. Skeleton, all of you are good. I think all of you are going to get 50 to 60% at ease. So you don't need to worry at all. You can just chill out here every day and help us with the ward work. Only thing is, yeah, 50 to 60% is a bit for your purposes dicey because it can be either this way or that way also. So for that, I'm trying to help you to add something more, which may be garbage to some people, but it is still relevant. It's not completely irrelevant. Because whatever you fill up the paper with, if you can make it in form of points, automatically points, marks will be added to it. It should be just relevant. Even your questions are relevant. You just say dysphonia, you discuss it in this manner, even if you do not know why it happens, then still you. Alright. Clinical features, definition, pathophysiology, history, pathology, clinical features.
Differential diagnosis includes yes. Drug-induced Parkinsonism.
So various forms of Parkinson, it is still Parkinson. But what else? I mean, etiology, you're going to etiology for the differential. What is causing the Parkinson? Like, what drug can cause Parkinson? Neat MCQ. There was a sudden spate of Parkinson's in young people. And now if I tell that they are not taking, you can tell us the thing also. Who were drug addicts. So they were taking heroin. And they're all coming with young onset Parkinson. What is that? EMTP or something like that? I'm forgetting the exact name. So, yeah, you can look it up. Yeah, you know it? Yeah. So, something, there was an impurity in that heroin substance, if I remember correctly. And that was causing the Parkinson. So, we had a drug-induced etiology to find out, I mean, as a model, that this can cause Parkinson like this. Others, of course, are degenerative, senile kind of condition where the dopamine is getting depleted. But is there a chemical which can deplete the dopamine? If so, then how is the chemical depleting the dopamine? Again, we need to look into it. We have to review it. So, that is etiology. Etiology is degeneration of the neurons or chemical depletion by other means like other chemicals, toxins. Any other etiological differences here?
Post-infectious trauma.
Yes, it's a very, very common thing. You know, many people in the pediatrics, if you are doing intensive design, you find they're having meningitis and encephalitis. And when you come to medicine, you find that those people come back with all features of Parkinson at a young age. Post-encephalitic Parkinson. From who is the most celebrated performer to have that? Yes, Muhammad Ali. So pugilistic Parkinson. So boxer Parkinson. So cranial trauma, urinary trauma can give rise to that. So some kind of mechanical stimulation is also causing dopamine depletion problems. If you are sure of that theory of dopamine depletion, dopamine running the entire circuit, basal ganglia circuit. So can you tell us more about this basal ganglia inhibitory circuit which regulates coordinates a little bit of physiology? So yeah, the idea, the formula and the skeleton for anything in medicine, any short note, long note is think of all the nucleus structures. Anatomy, pathology, I mean anatomy, physiology, biochemistry. We're discussing it. Physiology is how does this happen? How does movement happen? So you see all these things, anatomy and physiology, they came because we had patients and we tried to go back and try to decipher these diseases. That's where we started off with anatomy. Then we landed up with biochemistry and physiology. I think we started with anatomy, then pathology, and then everything else.
Actually, there are some Parkinson stimulate your cortex for starting for movement starting. Stimulation of cortex will cause starting of the movement.
Initiation of movement. Yes, that's a good thing. You have seen in Parkinson, you observe that there is initiation inertia difficult. If you see a person, he is frozen, he is unable to move, he is unable to start the movement. And if he is going like this, he cannot turn. To take a turn, he has to wait for a long time. So, as per Dr. Sandeep, the initiation is regulated by the cortical neurons, which are connected to the basal ganglia.
Basal ganglia to cortex.
Yes, there is a network from basal ganglia to cortex which initiates movement. Yes, because all our initiation is a cortical activity. When we think that I am going to move my hand, it's starting from the cortex. So yes, and it has to be helped by basal ganglia.
Okay. And in that pathway will inhibit this cortex. So and dopamine is like it stimulates the with substantial like the dopaminergic neurons are present with the connection with the cortex, like with basal ganglia and also with the subthalamic nucleus. So with that, dopamine will stimulate your directional pathway and inhibit inherent pathways. So with this, if any degeneration of dopaminergic neurons will cause your decreased stimulation of direct pathway and inhibition of inherent pathway will be affected, that cause your bradykinesia movements.
So, what are the mechanism explain? So we didn't catch that. So anybody else contact the video there on the page.
Normally what happens is I'll go in reverse order. This thalamus is controlling cortex. It is initiating, like facilitating the movement. So this is a stimulatory action from thalamus to cortex. So for this to happen, everything here should happen. So what is happening is the subthalamic nucleus. Subthalamic normally what it does is it inhibits the thalamus. So for the movement to happen, this inhibition should be gone. So what is keeping it in check? GPI stimulus is keeping it in check. This is inhibiting the subthalamic nucleus so that this inhibition is gone. So what is happening here? This inhibition is happening. The inhibition of subthalamic nucleus on thalamus is getting inhibited by the stimulus from globus pallidus interna. What is globus pallidus interna receiving signals from the striatum? Putamen and caudate. They are sending dopamine. So dopamine stimulates this GPI. So it successfully inhibits the subthalamic nucleus. So that the subthalamic nucleus's inhibition on thalamus is gone and facilitation of movement happens. This is what normally happens. When dopamine is gone, the GPA stimulation on subthalamic nucleus is gone. So the subthalamic nucleus is inhibiting continuously the thalamus. So the thalamus facilitatory movement on cortex is gone, and so the movements are getting decreased. That's it.
That was the movement pathway, which Sandeep has explained, and also Madam has shown us the visual different take on it. And next. So we have done definition, clinical features, pathophysiology, physically, anatomy, pathology, physiology, biochemistry, all those things are there. Now we move to therapy, pharmacology, non-pharmacology. Fantastic, fascinating. Again, is such a wide area. And if you just think of therapy itself, it's so huge. And there's so many people with Parkinsonism world over, even in Nagarjuna, Hyderabad, everybody. Many of the relatives are having it. So it's a very, very important thing. There's so much of evidence-based medicine here, so many trials, so many things. So this is really if you can put the evidence-based medicine here, this is really going to be it can fetch you 9 marks, 9 out of 10. So let's see how far you can go. We have reached 5. So therapy.
So after diagnosing Parkinson's disease, first we should see age of the patient. If the patient is more than 60 years, we can treat the patient with levodopa.
And all right. So treatment algorithm. So more than 60 years, less than 60 years. More than 60 years, give levodopa. Why? Explain.
Sir, actually it is Parkinson is a very long stage disease. So with initiation of levodopa in early stages, we can't use the tolerance for the levodopa, and on-off phenomena are very
good. I think the point that you're trying to make is when we give levodopa, it has a shelf life of 5 years. And after 5 years, all the patients who have been put on levodopa, most of them, will stop responding to it. So initially, if you give levodopa, it's fascinating, magical. The patients who are all frozen with that, they start walking normally within a few weeks. So it's really good. But after 5 years, all the same patients, they are not responding to anything. They've gone into the stage of complications, on-off phenomena, frozen, and all those things that you will, as a neurologist, you will have to bear all the brunt of it. So that's of course the point, that if we have to give this magic, if you want to magically treat early and show our cloud, yes, I have treated it, you can do that to get some brownie points. give immediately, and most people also do that. But yeah, it's ideal to not do it immediately, to delay it as far as possible. Very difficult, easier said than done. So yes, I agree. Now what? But then what is the efficacy of levodopa in terms of randomized controlled trial? Do we have any data? So when was it first discovered, and when was it first given trial? Was it a randomized controlled trial, or was it just a open label case series? So these are the things which we need to review a little bit, isn't it? To make your answer go to that height. Now, okay, what next?
And below 60 years, we should see whether it is tremor predominant or rigidity predominant. If it is tremor predominant, we should treat them with anticholinergics like triacylphenidine and benzoxide.
Okay, so what is the rationale giving the anticholinergics? It is a symptomatic relief. So there may be some efficacy of triacylphenidine, centrally acting anticholinergic, to reduce tremors versus placebo. And based on that data, we are giving them symptomatic relief for tremors. Okay. And other than tremors, what else is it?
Rigidity and
Rigidity. So rigidity is also
respond. We can give dopamine agonist.
So instead of giving levodopa directly, you can give some agonists of dopamine, which can behave like levodopa and may not, cause that levodopa problems. That is the levodopa inefficacy secondary. So that's the rationale. I think that's the thinking behind it. So, but again, yeah, it's a symptomatic reliever. Maybe the rigidity comes down. Now, you have to tell us what are the efficacy studies of dopaminergic agonists like bromocriptine in these kind of situations. Do they really bring down the rigidity? Have you seen any trials where people have been given bromocriptine versus placebo and then followed up and then seen how many in the bromocriptine group really had some relief, how many in the placebo group had relief? That you have to find and tell us. Okay, so dopaminergic agonist and triacylphenidine. Good. Let's move ahead. What next?
To prevent the peripheral side effects of dopamine, and we are adding levodopa with peripheral decarbonylase inhibitors like carbidopa.
What inhibitors?
Peripheral decarboxylase inhibitors.
So that's to inhibit the metabolism of levodopa so that the levodopa levels are remaining better, isn't it? Otherwise,
peripheral side effects of
whatever dopamine, levodopa we are giving to stop it from metabolism in the peripheral circulation, for it to enter and cross the blood-brain barrier, we are giving it with
so basically you are wanting to preserve what you are getting instead of letting it go down the brain. But does it have any other, like you are hinting at some that it prevents some side effects? Is that so? How?
peripheral dopamine.
So it doesn't allow it to go to the periphery and cause peripheral dopamine.
Yeah, and on peripheral receptors it attacks, and area posterior is also not protected by blood-brain barrier. So it acts on the inverse.
So it causes a lot of intolerance to
nausea,
dopamine.
vomiting.
Nausea, vomiting, and all that. So if you add benserazide, carbidopa, then it will not allow it to go to those peripheral areas.
It won't get metabolized in the peripheral circulation. It actually has time to cross the BBB and act on where we.
So because it is preventing its metabolism, it will.
Levodopa has to be converted to dopamine before it gets utilized. So levodopa is converted to dopamine, and dopamine will be utilized by the receptor. But once dopamine is formed, it won't cross blood-brain barrier. Only levodopa can cross blood-brain barrier. So peripheral dopamine is causing side effects. So in order to prevent peripheral dopamine formation, we will be giving carbidopa.
So it is basically delaying its transformation.
That's the reason for the dopamine agonists are also like all agree that levodopa has dyskinetic movements and on and off phenomena, all those side effects. But dopamine agonists have all these peripheral dopamine side effects like nausea, vomiting, other dopamine side effects and all. So that is one disadvantage of dopamine agonists. Levodopa, if we combine it with carbidopa, we can avoid all this. Like COMT inhibitors also we can try other than peripheral dopamine.
So this is a very good logic, rationale based on animal model studies to essentially, optimize the therapy of levodopa that we have added carbidopa. But now, what are the efficacy studies on this? Levodopa alone versus levodopa plus carbidopa, and outcomes of these things that we are claiming that it doesn't have. So again, you'll have to bring in a study to prove that yes, this is really what happens. So each and every logical thing which animal model studies have shown, you have to support it with a human study, a phase 3 study as we call it. Okay, so let's move to other therapy. So till now we have finished levodopa, we have finished the symptomatic reliever, dopamine agonist and centrally acting anticholinergics, sputtermans. What else? Yes. Yeah, that's very interesting. What is their role in this? And you will see many of the patients are copying them like anything. So what are they really? And then what?
They inhibit dopamine regulation.
Okay, so they allow the natural dopamine to. One is you can give dopamine extra, but otherwise whatever dopamine is there, it is inhibiting its destruction. So that can give you some more dopamine. But that does it relate to clinical benefits? Translate to clinical benefits? Anyway, it's not trials of MAO-B inhibitors versus classical. And then follow-up outcomes. And one such trial was a data talk trial, where I think they gave seliginidine. And that was very famous, and a lot of drug industry money was spent on it, and a lot of money was recovered data from patients. But did it really do well? I mean, were the outcomes really spectacular? So this really requires a journal come on, like the data talk trial, isn't it? So I'm hoping tomorrow we'll see that. One of you will be able to share, any of you. And just look at the figures from the PICO perspective. How many people were studied? What were the interventions like? How we seliginidine versus placebo? And what were the outcomes? These are things which you have to keep in mind. Keep the entire study so that the cross-examination we can again come back on the data. Because one journal topic will be given in your exam also. So just like data talk trial. Then we'll tell you, find the data talk trial, see this entire paper and critically appraise it. Tell us what is the efficacy of seliginidine versus placebo. So you have to do that. It can be done in the bedside also. And see, it's very useful in the theory papers. So yes, I think Sandeep has covered most of the ground, definition, clinical features. There's no other diagnostic tool here other than clinical features. Any interesting anecdotes you can tell us about clinical diagnosis in Parkinsonism, other than whatever clinical feature you see? Anybody? I have mentioned this anecdote to people who were in our unit. I mean, I also saw it in news articles.
Main thing now in diagnosis Parkinson is giving a trail of levodopa.
Yes, therapeutic response. So DOPA response is also there, but again, those therapeutic trials have their problems. Like they're open labeled and no comparators, so they have their problems. So there was this lady who could diagnose her husband's Parkinson's just by the smell. So she said there was some different smell to this person, and she was very, very sure. So the doctors tested her. So they gave her 10 Parkinson's patients and 10 non-Parkinson's patients, and they mixed them. And she just smelled all of them, and she said these are all Parkinson's patients. Actually, 9 out of 10 she got correct. So they were all surprised, how is it possible? And then, now we know, it's basically a huge development in the field. We call it VOCs, volatile organic compounds. So dogs can smell out multiple melanoma and so many things. I mean, dogs have a fantastic powerful sense of smell. So they can actually detect those chemicals which humans are not able to do. But some humans, like that lady, she had the power of detecting this particular disease called Parkinsonism with her nose. And this has in recent times been utilized by electronic engineers. They have prepared an electronic nose, e-nose they call it. And basically it's nothing but sensing VOCs, volatile organic compounds, and probably all of you will be using that as a diagnostic tool in the future to come, where you just put that thing there and see the chemical thing, just like you are seeing the fever these days by shooting at the person, and that will give you the diagnostic number. So, and later on the doctors found the one where she made a mistake, that patient later on turned out to have Parkinson. So she was diagnosing early Parkinson even before anybody could die, even before the experts could diagnose that patient. She had diagnosed that patient just using her sense of smell. So that's just an aside, but I think it is relevant to this Parkinsonism discussion. Now, Okay, good, Sandeep, you've done well. So who will be the next? Let us see. On the second way. I think you have to go close to a river.
First we have to know the real volumes of the lungs, like tidal volume. Because the normal volume during the inspiration and expiration, which are
While
not
your voice growing is important. It's not reaching everywhere. Either because
tidal volume. It is a volume which is during inspiration and expiration.
so this period volume, where it will start with an introduction. What is pulmonary function test definition? Why do we do it? And then the components of a pulmonary function test. This video started with the components. So tell us something about pulmonary function test. I mean, what is it? Why do we do it?
Pulmonary function test was done to differentiate between the diseases, whether it is an obstructive or a restrictive pattern, or whether it is a vascular disorder. So, in order to do that, the most common thing is
Function test. Essentially, you want to know how is the lung functioning. So by the lung function, you mean there are only two functions. Either it is compliant, which is a function, like how elastic it is, whether it is able to expand and relax. And the other is whether it is able to take in air. So if it is not able to take in air, that is also malfunction. If it is not able to expand properly, that is also malfunction. So we are testing these two malfunctions, whether it is able to take in air properly or whether it is able to expand properly. So that is obstruction and restriction. And so this is what we are going to look at. Now we come to the components of the lung function test, which will enable us to look at these two aspects of function. So you mean to tell us that there is no other lung function other than these two things, taking in air and expanding and accommodating that air, no other lung function?
production of angiotensin.
Yes, that's also very interesting. Right? Lately in the news, production of angiotensin. Yeah, and the receptors are all there. So one is that. That's endocrine function. So the lung also has got an endocrine function. Okay, what else?
Yes, it's a reservoir of
Yeah, it shows a lot of blood because of all the pulmonary venous capacitance vessels. A lot of blood is there. All right. What else? Yes. So it supplies megakaryocytes.
transformation occurs. So whenever capillary megakaryocytes touch the pulmonary circulation and reach the nail beds, that's the thesis for
Yeah. Why does the megakaryocyte choose that place to shed off into brain? I mean, is there something special about the lungs? Okay, so maybe when they're on their journey from the bone marrow to somewhere else, when they reach that capillary area, they are forced to break down. That's your theory right now, but we need to verify that. So what else? Yeah, we have some. Yes, very very important function, lung function test. You know, you started off straight away with this blowing machine, but there's an important machine which is just basically seeing whether your oxygen is reaching or not, and that is the gas exchange mechanism. That is the alveolar capillary membrane. So to test the alveolar capillary membrane, you have a different kind of lung function test, which is DLCO. Yes. So that is there. So gas exchange is important. It's not just the bellowing and the mechanical part, but also the diffusion of the oxygen. And what about carbon dioxide? Does it have anything to do with the lung function? Because we know if the lung is not ventilating well, carbon dioxide increases in the blood. In fact, the only indication for ventilation, to ask me, is hypercapnia. But that indicates hypoventilation. By definition, hypoventilation is hypercapnia. Only when your PCO is increasing, you can ventilate. That is hypoventilation. Ventilation is not required for hypoxia or even ARDS. I mean, we don't know whether it's helpful or not. Now, COVID is telling us it's not helpful. People are dying anyway. There's 90% mortality. Of course, we always knew that. We knew that before COVID also. When we were putting our patients of ARDS on the ventilator, majority were not coming out. But our renal failure pulmonary tumors were coming out. Our cardiogenic pulmonary tumors are coming out. You have seen that in the last 3 years. So when a person is affected by inflammatory response, damage of the alveoli, it's of course difficult to bring about, but yes, that's a very important function. But yes, PCO2 is again taken out by the lungs. That means the most important function of lungs is ventilation, and maybe that obstructive component, the compliance component, are the sub components of this ventilatory mechanism. And of course, it's not just the lungs which do that. A very important component is the structure around the lungs, the musculoskeletal system. So here again you will have to go into the differentiation of the lung restriction and the musculoskeletal restriction. Okay, let's move ahead.
Should I go with the spinal?
Uh-huh.
Should I go with the spinal?
Yeah, go with what you are starting with.
So,
You started with cardio volume. Expand on that.
it's a normal volume during the inspiration and expiration. It will be around 500 ml. And
What in the lung function does, what parameter tells you the cardio volume and what you do with it. Now you have put patients on ventilators and you have even fixed the cardio volume. That is when you are ventilating. But if the patient is spontaneously ventilating, it is showing you a cardio volume. So what you do with that information? That's a lung function test. Your ventilator is giving you all the lung function tests all the time. When you put the patient in ventilator, it is just throwing out all the data. The same lung function test data. It's a very, very important one. So how do you use the information of cardio volume? How does it help you? Anything cardio volume or not? Okay, so this is one point which we need to expand on. So can anybody tell us any scenarios low tide or high tide or okay, bad or trauma? And how is that related? What kind of volume? High tide. Okay. One is if you have high tide volume, then it will lead to a complication. That is logical. Yes. Of course, if you are pushing in too much of air into a small alveoli, it will damage. Simple as that. But so when the ventilator is showing you high tidal volume, when something is going in, it is likely to cause bad trauma. That's one scenario. But that's when you're giving. But let's say a spontaneous person who has blown into the pulmonary function machine, tidal volume is showing you. Is there anything?
shallow breathing. Shallow breathing.
Shallow breathing. That can be because the amount of air is not reaching there or is not going out. Yeah, we're just dissecting your concepts, because what we often do is we just read it in the textbook manner and we try to replicate it as it is without dissecting it, without asking questions. Now I'm raising questions and bringing forth doubts. This is stimulating treatment, and every day we will raise these questions and every day we become richer with these answers and we learn more and more. Our only aim in doing all this is to learn more. We are also wanting to learn more. So very good. So what about next? Other than kind of what else do you do?
Inspiratory visual volume.
Yeah. But
Inspiratory.
tell me, you have seen so many pulmonary hospitals, you reported them with the pulmonary OPD. When have you really seriously looked at tidal volume and inspiratory reserve volume there in the report? So what do you see in that report at the first place? Yeah, okay, so flow volume is very, very prominent, it hits you. So that's important. So can you want to talk about flow volume curve earlier? Or what else do they tell you before that? Yes, I think FVC is the most important thing that we always look at. So what does that tell us?
Obstructive disease, FVC is decreased along with FEV1 is decreased. FEV1 is decreased.
Increase.
E1, obstructive.
FVC is increased.
Decreased. Both are decreased, but it's still normal.
No, FVC is increased or decreased?
Decreased.
Okay. So everybody agrees in obstructive airway disease, FVC is increased. Increased. Decreased. Or decreased. Decreased. Yes, there is obstruction, so it has to be decreased. First, second, you are blowing in, there is obstruction, it has to be decreased. So FVC is decreased in obstructive airway disease. What about FVC? Will it increase or increase? Or normal? It should stay the same. If there is nothing other than obstruction, it should not logically change. So what will happen to the FEV1 FVC ratio? Yeah, it's very pretty. Now why am I asking this? There's another short note for you all. It's called PRISM. Preserved ratio impaired spirometry. That's a fascinating short note, which maybe somebody will respond on today or tomorrow. So yeah, so obstructive airway disease is that. And what about restrictive? Now you know FVC will come down, so the ratio will come down in this. But there is a very interesting entity where the ratio is preserved, but spirometric function is impaired. That means the FEV1 is reduced, but the ratio is preserved. What is happening? Where do you see this? We are not able to hear you. Yeah, exactly. I mean, basically, there's something which is going down simultaneously. So when does that happen? Yeah. So basically, mixed type of respiratory disorders, not just obstruction. You have obstruction and you also have restriction. That is where this PRISM phenomena often happens. And you will see a lot of them in our OPD itself. Most of them are having PRISM. And even the report is mentioning that. So I think one PG should be taking up the thesis of these kind of patients. Why is it happening? Why are they having mixed type of patterns? So if you are asked to write a short note on PRISM, you will actually look at the PG thesis around this area. And why does that happen? And then expand on it. So tomorrow one of you might have to just add a little bit of about this entity called PRISM. So yes, I think we have covered all the lung function tests. What is the time? Can we
25-year-old male patient, sir. 25-year-old male, non-alcoholic, non-smoker, and non-diabetic, hypertensive since 6 months. He actually was asymptomatic for a year.
Okay.
25-year-old male, non-diabetic, hypertensive since 6 months, and non-alcoholic, non-smoker. He was asymptomatic 1 year back, after which one day he developed a high-grade fever, for which he was taken to a local R&D practitioner, and he was prescribed paracetamol, and later he had to be even admitted in a local Nalgona hospital for high-grade fever, though he had no other symptoms like cough, burning, inflammation, loose stools, or vomitings. He was admitted there, where he was given paracetamol and he was discharged. After that, he continued taking these drugs over 4 months for whenever he had body pains or whenever he had felt weak. He kept using them on and off regularly. And later he was readmitted he was again admitted in London's hospital. But the data on this is not really clear because the attendants were not able to tell that why a renal biopsy was done in limbs. A renal biopsy was performed in limbs, and we don't even have a report of that. But he was admitted with fever according to them, and 2 months later he presented to Pulmonary hospital with generalized Ramsaka, reduced urine output, dyspnea, grade 4, non-productive cough, and fever. And on examination, he was found to be hypertensive, and they even told him that he required hemodialysis, and even he had bilateral pleural effusion, and we did a pleural tap, and the previous PGs told me that he was showed an exudative picture. So this is the case.
So this is a short case description by Dr. Ashita. She is managing the patient right now. We have about 9 very sick patients in the ICU AMC, as we call it, and this patient is one of them. And the first look at this X-ray you see, the current X-ray, you will think of COVID, because everybody is thinking of COVID anyway. And this is a very typical pulmonary edema finding which you see in many causes of pulmonary edema, such as non-cardiogenic pulmonary edema, like as in COVID, pneumonia, or cardiogenic pulmonary edema probably as in this patient, which could be because of a cardiorenal syndrome or just because of fluid overload. So now I want you to analyze whatever data you have received and tell us certain features about this patient's diagnosis and treatment plan. So who is going to do that? Deepak.
What are data that we have presented? Young patient with hypertension and renal problem. The first thing I would like to look at the urine analysis reports. If there are any RBC CAS, if there is any proteinuria and any hematuria on examination as well. I want to look at the urine sample first. If there is any macroscopic hematuria, then the microscopic analysis for hematuria in the form of RBC CAS and all. And I would like to do that first. And if there are conclusions that shows hematuria and RBC CAS, I would like to think it as an acute nephritic syndrome. An acute nephritic syndrome. And the past history of fever, which we are saying, I would like to further inquire about the details of any sore throat or any skin infection preceding to that renal problem. So which can shed light or it can say there's any evidence of post-epilocal glomerular nephritis. And other I would also, in clinical examination, look if there is any possibility of any renal fluid because he is a young hypertensive. So we should also look for any renal artery stenosis kind of history.
So any history of that?
And about the urine analysis.
He had albuminuria, sir.
How much?
And 3 plus.
So do we have a quantitative analysis?
Quantitative analysis, like the previous was there, was almost 203 grams. He didn't have any history of any skin infection or so.
What about the microscopic analysis? RBCs?
No RBCs.
No RBCs.
No RBCs.
So I think what we are dealing with here is a nephrotic range proteinuria in a patient who may have had nephrotic syndrome to begin with. Now, whether you call it nephritic or nephrotic, it basically tells you that it's a glomerular nephritis. And if it is less acute, just albuminuria, not much of inflammation causing proliferative hematuria, then it is nephrotic syndrome. If it is more acute, it is acute glomerular nephritis, also known as nephritic syndrome. I don't think these things matter much. It's the pathology which is important. So we come to the pathology of this patient. So what would we expect in the renal biopsy in such a patient? So Dr. Ashika is trying to get the renal biopsy report, but even before she gets it, what is the expectation, going by your experience and expertise in this field?
I would like to look for any epithelial deposits, mesangial deposits, endothelial deposits, subendothelial deposits, if there are any.
So first is you would like to divide it into whether it's a primary glomerulopathy or whether it's a secondary glomerulopathy. Now, as per Ashita's history, there are no features of secondary glomerulonephritis here. Secondary glomerulonephritis in the term that it could be associated with other immunological disorders causing the nephropathy, like polyarteritis nodosa or lupus nephritis or many other things. All antigen antibodies, cell-mediated immunity are related glomerulopathies. So nothing of that sort is manifest in the clinical features of history. So you would probably expect features of primary glomerulonephritis. So what is the division of primary glomerulonephritis in terms of pathology, pathological patterns in primary glomerulonephritis? Yes, one is, as you said, that. The other is, first you start with the commonest. What is the commonest pattern? Yes, the commonest pattern is normal. When you find a normal glomerulus in a person who has 3 grams of albuminuria, it is minimal change. And for all of us here who don't have access to electron microscope, it is a normal glomerulus. So minimal change nephropathy is common. That is one possibility. Second could be, yes, you were going there. Membranoproliferative, okay. Focal segmental glomerulus, very good. What else? Okay, IgA nephropathy, what else? Membranous. Yes, membranous. Alright, so these are the primary glomerulopathies. So what does it, how does it help you? You've done a biopsy, you've got FSGS, or you may have got membranous, you've got membranotolerant. How is it going to help you and the patient to make a decision as to this treatment plan? So let's say you are there 8 months back and seeing this, evaluating this patient in NIMS, and you got a report of FSGS. What would be your next step? Or you got a report of membranous, or you got a report of MPGN or minimal change. Depending on all these different reports, how you have changed your treatment plan. So yes, so that's the guideline that all minimal change nephropathies can be given steroids. Is there any evidence to support this guideline? Yeah, if you look at the adult literature on minimal change and steroids, you'll find that there are a few RCTs, but none of these RCTs have shown any beneficial outcomes. And why are we giving steroids to all adult minimal change? Because we do not have anything better to do. We do not have anything else. So we give steroids. So the usual normal pattern of nephrology treatment practices: start with steroids, doesn't help, then add adjuvants, other immunosuppressants like cyclophosphamide, cyclosporin, microvalent mofetil, azathioprine. So all these things you keep on trying, and finally the patient goes into renal failure. If he is unlucky, most of the time it is like that. And then you will tell us what is the percentage. Now here is where your renal biopsy comes in handy. So when you have done a renal biopsy, if it is membranous, you know that without any treatment, this patient has got 40% chance probably of spontaneous recovery. Membranous nephropathy, which is the commonest cause of nephrotic syndrome in the US, probably in India also, will spontaneously recover in many of the patients. So there you can even watch them without giving anything. Whereas in FSGS, it is 60 to 80% chance that they will quickly go into renal failure, chronic renal failure, and require dialysis, renal therapy or transplant, as the case may be. And MPGN is also quite bad, not good to have. Yes, post-structural pulmonary, if it was, as you said, AGN, acute pneumonitis with evidence of hematuria, smoky urine, hypertension, all coming at like a violent surge in the beginning because of some post-structural pulmonary. Then again, it's spontaneous remission. Most of them will just recover on their own. Because it's just immune response, just like COVID, 80% recover. Because their immune response is not strong enough. Those who are mounting a huge immune response, cytokine storm, they are the ones who are dying. So here, if you are not mounting that immune response to the global dust, you are likely to be surviving. Now what has happened to this man? Since last 1 year, he developed these immune attacks in his pulmonary, whatever it is, we do not know, which was producing all these immune violent behavior symptoms like fever, myalgia, for which he was taking NSAIDs, which was further jeopardizing his renal blood flow and probably adding to his renal failure. And now he has developed renal failure. It's almost like chronic renal failure. And he is on dialysis, chronic dialysis. And if he is not on dialysis, he is going into cardiorenal pulmonary. And that was the X-ray which he was supposed to show you. So what can we do at this point of time in this 25-year-old man? So maybe Kirti will tell us.
Maybe you can plan for renal transplantation.
Yes, I think that's the only thing we can do now is to replace the kidneys. Because anyway, dialysis also replaces renal replacement therapy. And the best renal replacement therapy for a younger person would be renal transplant. So we have to look at his transplant prospects. So how do you evaluate for the transplant prospects over 25 years? What will be the step-by-step procedure?
Yes, we have to enroll them in the Jeevan program. Then when you stay on him, then he'll be evaluated for the eligibility.
Okay, so I think you are talking about disease donor transplant here. You are talking about his own relative donor transplant. Well, I think disease donor is a good option. First option for who? For a good kidney and for the recipient. But for a donor, why should I give my kidney? Even if it's my son.
Considering the patient's age, it's more
No, that's okay, but who is going to give it? The mother? Father is going to give kidney. So, mother will have to give. And how much can you drain on the mother?
And they should not have comorbidity.
Yes, they will be having it. They're anyway not very young. So, they will have comorbidity, it's a problem. So, it's best to do disease donor transplant. Now, why is this not happening in Telangana? We are a Jeevan center, can you believe it? And till now we have not got any transplant done. No disease donor, nobody is willing to give their kidneys even after death. What is the problem here? What is the issue? You see, from this, if you are given a short note of renal transplant, you can write so much, so many things. So what is the issue in Jivanda in Telangana? Why are we not getting? So it's going to be a huge challenge. Slowly people come to the level of MBBS, MD, everybody, all the population. Then they will do it. So how will you fast track this process? Any ideas? Make everybody MBBS and MD. Automatically you will become DF anyway. How will you do that? So you have to, whatever you have got, you have to just give it to the bottom of the pyramid. All the knowledge and awareness. Make every citizen aware of renal diseases, membranous nephropathy, membranopathy, whatever we discussed today, everybody should be aware of it, all citizens. Then only they will be able to become that magnanimous and know the things as to why this is required and what can be done in this world. Because we are just manipulating, we are taking it from there and putting it there. We are not doing anything, we are not inventing things. Okay, so this one aspect which can be expanded on if you are at a loss for volume. And how did we go into that? Oh, from the case, yes. This case therapy is ultimately no component level repair here, but it's basically replacement. Mobile phone is not working, throw it, get another one. So yes, that's unfortunately all we can do in the entire field of nephrology. We will summarize what all we have discussed and learned from the interns. Yeah, she's sitting alone. So Hitesh, would you like to take the mic there? I mean the learning point summary. What all you learned? You came early. Okay, so you have seen everything. Start.
Firstly, learn about chronic fatigue syndrome.
Yes, what did we learn about chronic fatigue syndrome? At least we learned the formula. Anything in medicine, any syndrome, anything, any short note, we can tackle with a skeleton. That's also called a conceptual model or mental model. So you tell us about the skeleton. Anything in medicine, that's the same skeleton. Like we are all made of skeletons actually. Then we put on muscles. So tell us about the skeleton.
Definition.
Very good. Definition. So some definition of chronic fatigue syndrome. You can make it a person who is chronically getting fatigue without no other reason. Obvious reason. So that's one. So second, clinical features.
Diagnostic criteria.
Yes. So what are the clinical criteria, clinical features diagnosis? So the clinical features diagnostic criteria is a tool to kind of label a person as chronic fatigue syndrome. So what are those? Make it up. Don't worry. I mean, as long as you have this skeleton right, whatever you say will be approximately right. And you will get 60% marks in this MD exam. You are a PGY1, isn't it? Everybody is a PGY1 here. Yes.
Fatigue, myalgia, weakness.
Yes. Okay. So will Anvesh like to help us here again just as a revision? What are the criteria?
It should last for more than 6 months. You should not have any organic cause.
You see, any chronic is 6 months. So that's not a difference. Nothing like chronic fatigue syndrome. So just treat it like a common.
You should not have any organic cause.
Yeah, that's of course obvious. Yes.
You should not have any. You should not be relieved by rest.
Yeah, like when you are eating, you rest will become alright. Again, ready to. But here you take rest, you will even more people.
Should be associated with any of the four or more of the following features. Associated with sore throat, axillary and cervical tender lymph nodes.
Oh, fascinating. What is the cholesterol? So it can be associated with all these. This means that there is an infection hypothesis. And what are the infections which we have mentioned? What are those viruses which can cause chronic fatigue syndrome? Yes, one virus which is very famous for doing so many things. EPV, Epstein-Barr virus, there are all MCQs this virus can cause a lot of areas it can cover. So it has been postulated to cover chronic fatigue syndrome also. So when we say some kind of inflammation is happening in our body, inflammation as in the cell mediated, maybe the WBC is attacking, the lymphocytes attacking, that leads to febrile responses and most importantly fatigue. Even cancer fatigue is because of increased TNF alpha. That is because of basically it's a cytokine. So whenever there is increased cytokines in the blood, it will cause all these symptoms of fever, fatigue, myalgia, and in general, ill well. And in fact, they also feel depressed. A lot of depression is there. So in fact, many psychiatrists treat chronic fatigue syndrome as depression. So one of the therapies of chronic fatigue syndrome, other than CBT, cognitive behavioral therapy, he expounded only on the non-pharmacological therapy. But there are pharmacological approaches also, which he had left out. So amitriptyline is a drug which is often used in chronic fatigue syndrome because of the associated depression component. So basically all symptomatic. But yeah, CBD is probably not addressing symptoms, it is addressing the core of the problem. But then he has not expanded on CBD. What is CBD? Any idea? Anybody?
Psychotherapy.
Yes.
Where the patients are trained to
Can you demonstrate a CBD on one of them? Yeah, very good. All of you should go to the psychiatry OPD and see how they are doing CBD. It's fascinating. And in fact, it is an important technique for all of you to learn because it's very handy. Sometimes you feel depressed and you can self CBD yourself and you will be all right. Yeah, some of us are doing it anyway without knowing how to do it, but you are doing it subconsciously. It's basically keeping a positive target in mind and thinking positive thoughts. Yes, yes, and basically trying to take out the negativities. So each and every negativity will be made by a positivity, and you will drop the negativity, and that will elevate elevate you from the depression. So that's kind of the skeleton of it. So yes, but then we talk about evidence-based medicine, CBD versus sham CBD, if that is possible. So he is going to tell us about that, or you also. I mean, all of us can search the literature more if they are educated, stimulated. So that is one learning point about the chronic fatigue syndrome. Now we move to the next learning point. What was the second speaker? Learning point. The YouTube global video is on you. The world is watching. Tumor Lysis syndrome. I think something has been left out in the but it's okay. So, Tumor Lysis syndrome, what did we learn today? Yeah, a lot of MCQs come in Tumor Lysis syndrome. Hypocalcemia, yes, that is the answer. Yes, that's the most important thing to remember. All except hypocalcemia. Actually, there will be hypercalcemia, you will say all except hypercalcemia. Okay, then? Yes, hyperkalemia. Yes. 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 So what is the therapy? And prevention as well as therapeutic intervention. What is the diagram in Tumor Lysis syndrome? Which patients get it? What? Yeah, people who are receiving chemotherapy and very commonly associated with lymphoproliferative malignancies. Sometimes in some lymphoproliferation it can happen spontaneously, even without any chemotherapy, like Burkitt's lymphoma. So yes, good. So what was the next learning point in Arvind is going to tell us? Very good. So tell us about what we learned today in Parkinson. Pathophysiology. What did we learn there? Dr. Rosa had a beautiful demonstration of how it happens. Movement pathway. Can you tell us? Well, don't tell me. I mean, tell the internet because nobody can hear you. Yeah.
We will have basal ganglions. Main outward from thalamus, substantial inhibitions. Those will occur in movement disorder.
So output
pathway, basal ganglion. In normal and
GPI. So every level. And okay, yeah, go ahead. So everything begins at
Definition of pulmonary function is to assess the capacity of the lungs for ventilation and its components: tidal volume, inspiratory reserve volume, total lung capacity, and thickness ratio AP1 by APC based on it on percentage differentiating between obstructive and restrictive lung diseases and mixed pattern prism.
Other than in the ventilator settings, they don't mention it in the pulmonary function report. Yeah, that's it. Yeah, that's it. Yeah, but then we are how do we know what is the importance of inspiratory reserve volume, residual volume, tidal volume? Those things that we learn in physiology a lot. So what is the clinical importance of this? Yeah, yeah, more than that, some other devices are required. That is no bad. Last that is no bad. But then what is the relationship to this? What is the clinical importance of this? Instruments. Like if you are using a lung plethysmograph, what kind of diagnosis are we expecting to find? So I think this is some food for thought for the tomorrow, where we will all come prepared with these answers to these questions. Okay, so differentiating between hyperinflation and air trapping. So what is the clinical importance of air trapping versus hyperinflation? I mean, what will we do with that information? Will it change our therapeutic plan? Yeah, but after diagnosis is only important as much as therapy is available or some plan is available. So food for thought. So we will gather again tomorrow at 2 o'clock and hopefully discuss the answers to these questions.